All right, could the pandemic, the COVID-19 pandemic, be in its final days? Britain will start to roll out Merck's Molnupiravir antiviral pill through a drug trial later this month. Now, there's a Pfizer drug as well, antiviral drug. We've got, in addition to that, we've got 3 vaccines that are on the market. These pills, according to some, are cutting the. These are have been given to those who are not vaccinated, who end up sick, and it is having quite significant success. So we see all these things happen. I mentioned earlier in the previous segment that we see the number of cases declining. We see these new treatments coming online, lots of more tools in the government's COVID kit. So why the urgency to force Americans to get the COVID jab against their will? Well, it's one of the things we're talking about today. And joining me now to talk more about this, Dr. Andrew Bostom, an academic internist and epidemiologist. He joins us now. Dr. Bostom, welcome back to Washington Watch.
Great to be with you again, Tony.
Let's talk about these new drugs. They look very promising. What might we expect here in the United States?
Well, I think they are 2 promising drugs. What they show, Tony, is that, and this is really the drug model versus what's come to be the vaccine model. The drug model, and these drugs are both using methods that were developed through the HIV epidemic, but they target high-risk people in the trials. In other words, Tony, each one of these trials, which look very promising, they certainly do, were short-term trials in individuals at highest risk. In other words, they didn't willy-nilly start treating people at very low risk for severe consequences from COVID. They went right to the high-risk groups. They were fast, relatively small studies. Again, each study was less than 800 people, and they seemed to show very potent effects within a month. They treated early, they treated aggressively. They were both placebo-controlled trials, and they're using 2 different mechanisms to go after the virus. These different drugs. One is very, very similar to what's done with HIV. It's protease inhibitors. In other words, we have that if you recall now, Tony, we have this highly active antiretroviral therapy, HAART therapy. This is really analogous to it, the Pfizer drug, which is called Paxlovid, and it's given with another protease inhibitor, which is used in HIV to boost the levels of the drug. And they showed an 89% reduction in the combined endpoint of hospitalization or death within this 28-day period. Again, but targeting high-risk individuals.
Well, Dr. Bostom, if you're targeting the high risk, then those that are lower risk, should they not have as much benefit from a drug such as this as well?
Right, but the point is, this is the traditional model, Tony, is that you develop a drug in the highest risk, and
right.
If it's successful, treat them first, and then sure, but it takes a lot more people to study, and then the risk-benefit ratio changes because all drugs are going to have side effects. But here, the bang for the buck is very significant. The pretty much the same thing with the Molnupiravir, which is the Merck drug. It's a slightly different mechanism, and there's some concerns because it actually induces mutations in the virus, which then prevent viral replication.
Right.
But the question is, will it do the same to healthy cells? And I noticed in the trial that they excluded. They told men not to refrain from heterosexual activity or to use contraception, and they said we don't know if there's any potential effect of the drug on sperm. However, if you're dealing with a high-risk 70-year-old male, I mean, this may be a perfectly adequate drug. But there's a few more questions, about the Molnupiravir. But the point is, Tony, it's very different than these mass vaccination programs. And remember, we never developed a successful vaccine for HIV. We worked more along this kind of model and made it a very, very manageable disease. And I just think there's a lesson to be learned here And I do agree with the comments. You're already seeing, actually, Tony, you're already seeing declines in stock prices for the vaccine manufacturers as a result, particularly of the Pfizer
Well,
antiviral combination.
the stock market tells you a lot when you look at the
It
risk
does.
and reward. I want to make sure our folks didn't miss what you said. 89% effective in cutting the hospital stay and preventing death.
Yes, but again, very small study, Tony. So
Right.
what's interesting when you compare the two studies, the event rate in the Merck study was twice as high as the event rate in the Pfizer study, and both studies allegedly targeted high-risk people. So you see, when you have a small sample, there's a lot of variability. The consistency, though, is the dramatic reduction in the outcome relative to a placebo control. I mean, I think both drugs need more study. But for the very highest risk persons who are at death short term, or at risk, risk for death or hospitalization short term, I could understand why you would get an emergency use authorization for drugs like this. But I just think the whole idea of treatment of COVID, and it should have applied to vaccination, should have always been to target those at high risk. I mean, the vast preponderance of the population is at risk for a relatively mild and self-limited flu-like syndrome, or even a cold in really very immune kids.
Right.
And so that the development of either the vaccines or the drug should always have focused on the highest risk. And the good news is that we may have two potentially helpful drugs.
I mean, it's more efficient and effective. We don't have to shut down all of society. We don't have to muzzle everyone. And we don't have to create this political firestorm resistant to
and expose people to unknown risks. I mean, it makes more sense this way.
That's why they didn't do it.
Well, I hope we move forward with some more common sense now with these tools available to us.
Yeah, I am agreeing with that. I'd love to talk more about this. In fact, we will in the days ahead, because I've got some other things I want to talk to you about. But we're out of time for now. Dr. Bostom, always great to talk with you. Thanks so much for joining us.
Take care, Tony. Bye-bye.